What is also undergoing a frontline setting is that we have been able to identify prognostic markers because still the poor risk patients do poorly regardless of what you do. And that's the problem in mantle cell lymphoma, because again, they become chemo-resistant over time. So what are the poor risk? The high MEP patient, even with after high dose therapy, they clearly do worse. The patient will have high KX7, more than 30% or and above, and the patient who have a blastoid presentation or p53. And I think one of the most important factors that is likely underestimated is the presence of p53 abnormalities, either deletion 17p, but more frequently 17p mutation. And we actually do now test routinely patients. We have done a pilot study and done next-gen sequencing and found that among the abnormalities that we found was obviously ATM abnormalities in mantle cell lymphoma is very common, but also up to 30% of patients having p53 abnormalities. And these patients, we have shown with hyperCVAD, but it has been shown in Europe as well, after high dose therapy and transplant, do very poorly. So these patients need new options, regardless of the age. And that's where the stratification is going in mantle cell lymphoma, is that identify a subset of patients where we have to use a chemo-free option, because that is not dependent on p53 pathway.